Meningitis?
The new meningitis I read the other day, the Neisseria meningitis W version, apparently it can present quite atypically with tummy upset. So it's not just the headache and the neck stiffness and the septicemia. Now they're presenting with tummy upset, which is just adds to complexity.
Well, the other thing actually is severe leg pain is a problem in meningitis, and I think it's because the bone marrow expansion. It's the reason why you get back pain and influenza. You get this massive immune response, because back in the 1918 flu thing, people used to die. It used to be young people dying within about 8 or 10 hours of this acute allergic reaction. Their lungs would full of fluid. They'd turn black and die, and so that's influenza. And I think the same thing happens with severe meningococcal disease, is that you get probably bone marrow expansion in the leg. So severe leg pain is one of the predictors of. I mean, if you saw a kid with bilateral severe leg pain, you would probably wonder what the hell was going on. It would be out of kilter. And I think it's one of those things. I remember admitting a kid to hospital because his feet were doing this. He was about 18 months old, and I'd never seen it. And I referred him through, and he actually had a pneumonia, which was quite interesting. You know,
he was
septic, and that's how it was showing up. I mean, I just thought, this is too weird. You know, if it's weird and out of my standard 95% standard deviation, they go to hospital basically. So I suspect if you saw a kid with bilateral severe leg pain, you know, presumably afebrile, you would probably want to refer them in. Or talk to a paediatrician, and the paediatrician's amazing. They pretty well accept everybody. They'll give you useful advice by the phone, I find. But you know, if they were the slightest bit worried, they know they're not looking at the kid, and you are, and they're not going to take a risk. They know how sick kids get very quickly.
I'm just wondering if that kid was vaccinated.
I can't answer the question. I don't know.
Against meningococcal disease? Or?
Well, I'm just looking because I don't have that off by heart. But what is in the? This is the.
Meningococcal not one of the vaccines.
No, it's only for high risk.
It's only for high risk, so it's not. It's not one that children get.
No.
No, it's what Lance Gravatt from Tiara is trying to work his way towards, because that's what his boy died from.
The one we used was the B.
Oh yeah, that was that one. So now it's only for those high risk groups like university students and things. For people. Yeah, but so the new ones have been W, I think. Yeah, it's a nasty business. Anyway, you think about it, you've got to treat with some, you give whatever antibiotic you've got and you call the ambulance.
And you don't worry about, because in the old days people didn't like that, but with the PCRs now they can tell, so they're not worried about getting the organism. In the old days the issue was you'd muck up the blood cultures but these days with PCRs they can figure the organism out, can't they?
Yeah, and I mean I know we were purists like that, but actually the patient is the primary concern. So actually we know what the disease process is, risk benefit, it's best to give something.
And the monkey's on your back at that point once you. And the other thing is, I'd always send people by ambulance, because we had a guy, he was admittedly an adult who looked like he had septic shock, and we referred him to hospital, and my colleagues sent him by his own car. He didn't turn up till the next day. He actually turned out to have acute leukemia, I guess he would have been dead if he'd had septic shock, but we just thought he would go straight to hospital. So if somebody put people in an ambulance for your sake, don't rely on people.
Not driving either, so for everyone else's sake out on the road.
Well, or family. Normally it'd be a family member who would take them in that situation. But if they needed immediate hospital care, they need an ambulance basically. Otherwise, the monkey's on your back. So that's cellulitis, the BPAC update. There's this whole issue with flucloxacillin of with and without food. They've done that work in Christchurch. They found actually they got better blood levels if people took it with food.
Well, is that because the compliance has been done?
Well, possibly, and I think that's the thing you have to say to patients, because if you've ever tried to take an antibiotic 4 times a day, the only time you remember is when you put food in your mouth. I mean, it's just about impossible to take a drug unless you set your alarm on your phone.
And kids nowadays have always got food in their stomachs anyway.
Yeah. So BPAC suggests erythromycin. As I say, my experience is and that's a pretty big dose, I think. And I prefer roxithromycin for 5 days. Cotrimoxazole or cefalexin. The nice thing about MRSA is that it's sensitive to all the old-fashioned drugs that were around when I was a lad. I keep thinking it's going to be some whiz-bang drug, but I always like to tell the medical students these were around when I was a student. So, so Cefalexin for taste. Do you need QID or BD's normally enough? I think. Isn't
I think QID.
QID. Okay.
I think to have it. I think to have it BD, they take some probenecid with it.
Impetigo. Okay, so there's those of you who got my gems will have got the one stop using topical antibiotics. Anyone remember that one? Actually, it was quite neat because BPAC did a thing on it, and the national prescribing, there was a big dip, so we were quite... Because you wonder how often people take any notice of what you put out. And obviously, fusidic acid went up a little bit, but there was actually quite a big drop, so we were pretty tickled. It's one of our favourite slides. And so what's the deal about topical ointment? We want to the resistance rates are quite high, about 40 or 50%. When it was made over the counter, it went like from 5% to 40 or 50%, sort of overnight almost, because every man and his dog started using it literally for their dogs. And we want to keep it for getting rid of nasal carriage. The real problem, of course, is it's going to be used so little, and then it won't be available, and we won't have it for nasal carriage. So the suggestion now is hydrogen peroxide, which is funded. I think there's an iodine ointment that is funded, is it? Do you recall? Eh? Yep, it is.
But it's brown.
It's a really brown.
Browny orange.
Yeah, but on your skin it's brown.
Yeah. Nice and bright.
And Emma Best is doing a study at the moment, isn't she, trying to compare hydrogen peroxide to antibiotics, isn't it?
I think I'm a co-investigator.
Are you?
I don't know, I'm a co-investigator on all sorts of things I can't remember.
The trial is clean and cover,
Yes.
hydrogen peroxide and sodium fusidate.
Yeah, so it's got 3 arms, hasn't it?
Okay, human and animal bite, clean and debride. If it's in the hand, foot, face or tendon or ligament or untreated bite for 8 hours, then augmentin is okay. So this is one situation where augmentin is okay, or amoxicillin clavulanate bites. Well, it's back to augmentin as the funded one now, yeah. Or you can give metronidazole plus 200 stat doxycycline for that. And kids, it's well, I didn't put the dose in that because it's got too much. So these are high risk. So a bite in the thigh or calf or forearm or back wouldn't be an issue, but all these other places. So augmentin's okay.
Oh, can I just say one thing about cats? Cat bites are nasty, filthy. So I'd be more erring on the side of prophylaxis even around the cat bite.
Yep.
Because particularly around the hands, and then they get very nasty tendinitises and cause the plastic surgeons a lot of grief.
And I thought I'd just talk a little bit about how many of you are treating acne with isotretinoin here? You have a great joy in front of you.
Has that only just become GP?
No, it's about 6 or 7 years, and now Marius Rademacher in Hamilton has come up with this low dose option. So instead of giving 40 milligrams a day and causing these teenagers to have cracked lips and red faces, they just get a bit of a dry mouth on the 10 milligrams a day. The only downside of the low dose is the relapses tend to come a bit sooner. They still come, but they just come a bit sooner. So the issue now, it's an amazing drug to use. The numbers needed to treat are 1. Everyone gets better if they take it. It alters the secretion from the sweat glands. And it's sort of, when it works forever, it literally turns off that function. So there's none of the little sort of soup that's coming out that allows the bacteria. And I have to say, if you can't find a scar on a patient, you're meant to try doxycycline or topical. I'll go through the alternatives because I've got those. Relapse is about 40 weeks on the low dose. That's what happens. So 50% recurrence at 5 years. 80 weeks for higher dose. This is a massive dose. I mean, a guy, I'm 90 kilograms, you'd be giving 90 milligrams. And, you know, you could see the kid across the room. Any of you who were ever on it, you would have been on the high dose, and you could see you across the room.
So I was on 10 milligrams once a day. This was 20 years ago. And, I think he was quite I suppose he would have been one of the kind of outsiders doing it back then, but he was a big believer that he didn't need a big dose.
Really?
And
Dermatologist.
Pardon?
This is a dermatologist would have
Yeah,
been.
and then I went on it again a couple of years later because I had a clear and all the rest of it. And I've probably done about 3 courses. In my
Yep.
life, but always at that small dose.
Some women do need to have multiple courses, often early teenage years, mid-20s, 30s, and then again 40s and 50s. So women do need more courses. You can give 10 milligrams on alternate days, and after that, he just gives people a prescription and lets them take it for as long as they want. Once you've had a primary course like for 6 months, I always take photographs of kids and they don't usually mind me taking a photograph, even though they've got these pretty poxy looking faces. And I say, because I want you to look back when your skin's perfect at what you look like before you went on this. And do they remember to take their medication? They sure do. Which they don't with the they probably miss a few. And the problem with the doxycycline, one of the reasons it probably doesn't work is because they don't take it, they forget. So that's probably a problem, that's what he thinks. I sort of think it probably doesn't work. It's working as an anti-inflammatory, not as an antibiotic, and he thinks it's a bad use of doxycycline. And if we're trying to cut down the amount of antibiotics, and this stuff works to everybody. The other interesting thing, he thinks the 10 milligrams a day is below the teratogenic level, he thinks. But if you get pregnant on it, you're generally offered a termination. But I don't know where he gets that from, but he's been the world leader on this sort of stuff. Patients then decide when to stop. He says stop using antibiotics. So mild disease, you can use benzoyl peroxide or hydrogen peroxide, and hydrogen peroxide's funded, or azelaic acid, which isn't funded, or a topical retinoid. I think there's a couple. There's different and one other, I think, that are funded. Is that right? Different. Moderate for women, they can take Jeanette, which has got the cyproterone acetate in it. And then after that, it's isotretinoin. So I desperately try and find a scar on somebody so I can offer them isotretinoin. And if they've got a bad acne, you might as well, honestly. It's too much fluffing around, I think. So technically, according to the special authority, but you can usually find a scar somewhere.
They say to move away from cyproterone because of the thrombosis risk?
Yeah, it's the risk goes from about 1 in 3,000 to about 1 in 1,000. So it's a fairly low risk, and it's just a risk of DVT, not VTE or death.
There was one from Stosh, like dural venous sinus thrombosis, isn't it?
Sorry?
There was somebody who was speaking in Auckland with a venous sinus thrombosis.
Oh, really?
Brought it down to like genetic stuff.
And it's all due to the estrogen dose, possibly. There's just a paper out last week to show. It's a pity there isn't like a 20 microgram of ethanol estradiol with that. That would make it a lot better. 2 groups who miss out, women and those who scar easily. So you shouldn't be fluffing around with someone who's got scars. You just want to get on. I mean, you see these people as adults, and it's just... and I'll tell you what I do in public. So it also helps seborrheic dermatitis and dandruff. And the BPAC guideline says you need to do investigations, because there is an issue with some people where the lipids go up and they get pancreatitis and things. We haven't had any of that in our clinic. We had one person whose liver function. I normally do a couple of blood tests when they're on the medication. For the women, I do a pregnancy test. The evidence is pretty weak for doing that. But I do a thing, and I'm going to put it in as a Christmas BMJ. It's called the Good Samaritan Urge. When I see somebody in public with severe acne, I get my business card out and I go up to them and I say, look, I notice you've got a problem with your skin. I'm a doctor, and this is a drug that works for everybody. You need to go and see your doctor and get it. And anyway, so my wife hates me doing this, so she cringes, and my family sort of, he's at it again. But I've followed up 2 people on this, because I approached them on my gym. You have to be a little bit careful being a man my age approaching young men in the gym. But anyway, so I phoned this guy up. This is 6 years after this happened, and he was working in Canada. He said, that was fantastic what you did. He said, I was 19 at the time, and I was starting to withdraw socially. I'm a completely different person because of having that medication. So that keeps me going.
Well,
and that's going in the BMJ this year. And I hope it'll be my number 3 Christmas BMJ, so it'll be amazing.
I think that's great.
Yeah, so we're trying to encourage young doctors and nurses to, if you see something in public, do something about it. It's actually made in New Zealand now by Douglas. They cracked the molecule, and so they're now making it. It's quite a difficult drug to.
Is it off patent?
It's off patent, yeah, and that's why GPs and nurse prescribers can prescribe it now. I think I don't know about nurse practitioner. Whether the nurse practitioner is able to prescribe isotretinoin, it might be just one of those little wrinkles that hasn't. Because I know I talked to our NPs about it, and they weren't. But it's a fantastic drug to use.
What about the suicide stuff?
Okay, so the problem is there's no cause and effect, basically. I mean, where is the peak of depression and anxiety and suicide? It's in 20, and we know depression is related to severe acne. And if you say to these kids, you know, you're going to have a fantastic skin in 6 months, I mean, that's the best hope you can offer them, because they'll be withdrawing socially. You know, and withdrawing socially is the first step. You know, suicide follows people withdrawing.
In regards to those that already have maybe some mental health background and things like that?
You just have to watch them closely, discuss it with them, but some of my colleagues have stopped people because they've thought they've got depressed, but the problem is, you know, 40% of the young women you're seeing in primary care have a major anxiety or depression disorder, you know, when they come and see you. It's absolutely massive. So of course there's going to be huge overlap. They didn't look at mood in the trials, that was the problem. They just looked at skin outcomes and things. So we don't know about cause and effect. And I suspect there may be the odd person who gets a low mood, but you know, none of my patients have had that experience, and just seeing these kids with beautiful skins is just amazing.
Where did that, or may I ask, where did that come from? Your 40% of young women have anxiety.
That comes from the Magpie study.
Is that
in Wellington? Wellington, yeah, Wellington GP. They screen people from the waiting room. 40% have an anxiety disorder. Sometimes it's around the symptoms. I mean, of course, you come in with something and you think you're going to die from it if you're 20 years old. 20 years old think they're more likely to die than 80-year-olds.
It's awfully high, though.
It's huge.
I mean, it's an indictment on society, really.
Well, there's some evidence that actually hasn't changed in 40, 50 years in Canada. I just think young people have, you know, it's a distressing time of life.
Right.
And it's hard to know whether it's increasing or decreasing.
Okay.
It's
so there's some evidence that it's just normal.
Yeah. Trouble is they use different instruments, and so it's a bit hard. You go back 40, but there is a study from Eastern Canada, whereas the anxiety rates haven't changed in 40 or 50 years. So.
There are only kids that are presenting to a medical practice. They've probably got some health issues anyway.
Yeah, so they're probably...
Well, they're anxious probably about whatever they've got, you know, as they think they're going to die, and they... it was just... But also, or it's the anxiety, they're an anxious group, and that's leading to symptomatology. There's a huge... Yeah, there's a lot, you know, it's a difficult time, and Facebook probably isn't helping these days, you know. I keep seeing teenagers in my mental health stuff, you know, who have been bullied on Facebook, and there are more ways to bully people these days. Augmentin, so there's only two first-line conditions, the human or animal bite and diabetic foot infections. So how do you tell if a foot is infected, would you say? Because you swab them and you're going to get a little garden, aren't you?
Yeah, I think it's clinical, so wound breakdown, the wound breaking down or slow to heal, or surrounding cellulitis.
Do you measure CRPs and things? How useful are they?
I think CRPs are probably, I don't know exactly how useful they are, but I do know that in some patients with osteomyelitis in the foot, the CRP will be normal. Because it's too little to give that good... good systemic response. So I think in feet, diabetic feet or chronic ulcers, it's clinical in terms of... And they say like in chronic ulcers...
And we just x-ray them as well.
Oh yeah, in the feet, yeah. But then if it's early in the process, sometimes that can be falsely negative. Yeah.
Just a little thing you probably haven't heard of for venous ulcers is there's a drug called pentoxifylline. Anyone come across it? I was part of the systematic review with Andrew Joel, the Cochrane review. He's a nurse in the nursing department. And, you know, compression is the first line treatment, but actually pentoxifylline, and it is funded. There's a part charge on it if patients aren't getting better or they can't tolerate compression.
And how does it work?
Well, you know, when I was graduated, it was considered to be, it made the red cells flexible so that they would, it was marketed as a stroke preventer, but it didn't prevent strokes, but it does heal up venous They're not quite sure on the mechanism.
But that's fantastic if it works.
And it works.
Because the morbidity is huge.
I know. And it's virtually not used in the vascular clinics at all. Andrew cannot get the vascular clinics. I think they're so either surgically oriented or compression oriented, nobody will think about it. But, you know, if you want to wear compression bandages in the middle of summer, good luck to you, folks.
Yeah.
Maybe okay in Dunedin, but not in Auckland. You know, I would go for the pentox, you know. And it works with or without compression as well. And there's about 20 trials on it. I mean, it's not as if there's an absence of evidence. And they're all pretty... Pentox, Pentoxy. You often have to put Trental into your computer. That's the trade name. Because sometimes it's oxypentaphyllin, and I'm not sure how to spell it. I had trouble prescribing it, and I just did it recently on a guy who actually had ulcers up here with good arteria, had a good arterial system, so his ulcers probably were venous.
So what does this do?
It fixes venous ulcers. We don't know the mechanism.
Yeah, that's good.
We didn't know the mechanism of penicillin for the first 30 years, so...
But it's an antibiotic.
No, it's an anti-ulcer. Yeah. It probably does something to the vasculature, but I guess nobody knows. Well, what setting are you in?
So general practice.
Yep.
And there's a few people who I know would love to try that.
Yeah, and it's partially funded. You know, it's well funded. So.
Oh, there's a question over here.
Yep.
This question about cellulitis. Is there any advantage of adding clindamycin to flu clot?
No.
You'll give the patient C. difficile.
Yeah, I think we use flu clots if we think it's going to be a staph or an MSSA, you know, normal Staph aureus. And so the only time you'd be using clindamycin is where you think it's an MRSA, basically. So I guess there is that issue, and Mark Thomas was always interested in this, but it was more for neck fash, as to with neck fash and it's group A strep and you're giving a penicillin and then you're breaking up the cells and allowing all those toxins to be released. And the idea about giving clindamycin in that setting was that clindamycin's action is at the level of protein synthesis, so you're stopping the protein synthesis, so in theory you're stopping the toxins being produced. But it's theoretical. But so for neck fash, so they do give both. But in the community, no, we should be aiming at, and also we think it's more group A strep anyway than Staph aureus often, unless someone's got sort of a wound. So flu clots alone should be sufficient. But there is all those issues about people not being skinny. That's my polite way of saying fat, and people not keeping their legs up. And also, I've got a theory, and I think it's true, that, remember when we were, of those of us who were med-reggers, when you admitted the patients with pneumonia and discharged them, and you always gave them a form for a chest x-ray a month later, because it was only a month later that there was proper clearing, even though they were better, the clearing of the chest x-ray wouldn't be for, and so that's to make sure that there's nothing underneath, I reckon cellulitis is a bit like that, isn't it? So you give the antibiotics and the underlying infection is gone, but the redness sticks around a bit longer because it's an inflammatory thing. So I always think in my mind that cellulitis is a wee bit like those.
That's the current thinking, isn't it?
Yeah. And so if we only look at the cellular, the redness, and who was it who was saying you get them to stand up? Someone recently was saying that, it was my colleague Tim Blackmore saying that a patient will say, but look, my cellulitis is still bad. But he said if you get them to sit down and put their leg up, is that right? And then, only then can you say that it's red, because actually sometimes it's no longer red. So I think we overtreat cellulitis, in that we treat too long, because we go, oh gosh, it's still, the redness is still there. But actually, if the patients have taken the medicines,
this is the immune system's taken over.
Yeah.
So it's a matter of holding a nerve, isn't it?
Yeah.
If you want.
You would advocate that if somebody's got cellulitis in a leg, as a GP, you should examine on a bed and not in a chair.
That's what they're saying. Yeah. Get
Nice.
them to sit down, leg up, take the
Nice
history,
trick.
lie down. Yep.
Nice trick. Boils. Okay, so this is actually, I just looked at the recent meta-analysis on this, and you know the BPAC stuff is incite and drain, And I guess the issue is, should you take a swab or not? We tend to in South Auckland because there's a lot of MRSA.
The paediatricians would say it's starship that goes away anyway. That the draining is the important thing. But
because the downside is antibiotics do help from this meta-analysis, but whether, as you say, it will get better anyway, it's just a matter of how quickly it
so
gets better.
I don't know if a swab's... Everyone does swab. One of my girlfriends got recurrent boils, you know, because you acquire a particular Staph aureus into your household, and then you get these recurrent boils that go through the household. She said it was absolutely gruesome. She said, I've never had a boil. She said it was unbelievable.
Oh, because of the pain.
Yeah.
Well, the pain,
She said it was just terrible.
Yeah.
And sometimes people have like 3 or 4 episodes of boils before we manage them effectively, because the GP is just giving antibiotics, which is fair enough for the first or second one. But I think after once you're onto the third one, I'd be picking up the phone and getting the good drugs.
Are you going to tell us about the good drugs in a moment?
Yes.
Okay, so there's some good news coming this afternoon, guys. So cefalexin in children, they're recommending, I don't know what the dose is, and flucloxonazole. If you're doing nasal swabs, you do have to write checking for recurrence or nasal carriage.
And you just do the inside here, not back there.
Otherwise, they'll reject it. So, yep.
So management.
Yep.
What do you guys do?
In the old days when I was a public health physician, I would use, it was amazing.
Yeah.
About half the people would just clear. These are people who've been bugged by staph.
Yeah.
It was amazing. Now I have to email you to find out.
I know.
But it is a great option if you're getting recurrence. So you give rifampicin and Fluclox for a week, a month, for 3 months. And in my experience, it's about half the people, it should be.
Those people always said it was about 95% efficacious. I think that there's quite a few issues though, because say you've got one family member, say mum, and then there's a dad and there's 3 kids, and say mum and 1 kid have come to see you as the GP or the practice nurse with various boils. Do you swab all the family members? Do you swab just the ones who've got the boils? So I think that's the first question, and I don't quite know the answer. I think the reality is that other family members could be carrying that same germ, and so it's probably not a bad idea to swab all the family members, but just make it clear why you're doing it in the request form. And then the patients come to see you and they want it all sorted out then and there. So you can start them on their management, but it's worth getting that other information. I think it's important if you are treating to treat everyone at the same time. So say mum and the 3rd child have got the boils, and the 2nd child and dad turn out to be colonised. You really want to decolonise them at the same time as you're treating the first course with, so it's all coordinated. There was a paper from Germany. It was a village that had recurrent boils going round and around the village, and they described in the paper what they did. It was classic because it was so German. You know, they scrubbed and they everything was labelled. This is my towel. This is my comb. Do you know what I mean? And everything was sterilised. It was just, and then do you try to do topicals first, or do you just go to systemics in those people who have got boils? And I think it comes a little bit down to a discussion. So if, say, mum is pregnant, I would try and just manage the boil with a pregnancy acceptable drug like Fluclox, and then try and decolonise with topicals, because you just want to avoid so it does come down a wee bit, or the patient is on loads of medicines, and so drug interactions. Rifampicin has drug interactions. I wouldn't ever recommend systemic antibiotics for clearing carriage, because I think that when the person who had carriage and no infections turns out to have a hepatitis needing a liver transplant, you're on the back foot medico-legally for giving a systemic antibiotic for carriage. Not that, it's just, I just think in the balance of risks and benefits. So I always say, and then the other thing is, that people with bad skin, if they've got eczema, which there's heaps in South Auckland, it's really hard to clear them. So we always say you've got to try and get the eczema under control before you start this business, because if you start this business and the eczema's not under control, you won't clear them, and resistance starts to. And rifampicin resistance can emerge if I'm covered in Staph aureus and I take rifampicin on its own. The Staph aureus will start exhibiting resistance in about 3 or 4 days. So rifampicin always has to be used with another drug, and you have to impress upon the patient you must not only take the one drug. And then the rifampicin gives the orange tears and the orange urine, so, and drug interactions and the oral contraceptive pill and other things. And as I said, and then the other thing is fomite. So particularly the people with the flaky skin, full of Staph aureus, drops on the floor, gets through the bed linen, da 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 da. So I always say lots of care and attention to housekeeping while they're going through the decolonization process. Lots of vacuuming, lots of washing of the bed linen, not sharing towels, etc., etc. Because it can be a real palaver, and actually for a family it can be quite expensive to get this sorted out, because it's not just one person's GP visit, it's multiple. And then I had a call a year or so ago from a family where the relatives, there was a new baby in the house, they had relatives visiting from the UK, they're not eligible. Do you know what I mean? It's just a real palaver, so it can be quite a lot of work. And I'm happy to have emails about this sort of thing, and we actually try and work it out through email, because it often needs a lot of, So
in terms of topicals, do you have a preference for fusidic acid or
we look
mupirocin?
at the susceptibility.
Oh, do you? Okay.
Yeah.
Good.
Sorry, one of our management processes is that we often encourage families to, like, Urotales and stuff, but if they're particularly recurrent, is looking at things like bleach bath.
Yes, sorry, I forgot to mention that. Yeah.
If necessary, a betadine wash.
Yep. Yep, sorry, I should have mentioned that. That's all part of it. Yep, the bleach baths, because it's a cheap way of doing things. Because chlorhexidine washes are not funded. The other thing is gargle. So if you're trying to decolonize topically and it doesn't work as well as using the systemic antibiotics, we're putting it up the nose, but we're not actually doing anything. So it's decolonization topically is better if you put it up the nose and you do bleach bath, but also if you get the chlorhex gargle, and that's partially funded. Because people get, if you look, so the main area of colonization is the nose, but the throat is actually second. So I think people get recolonized from the throat. So if you are going to try topical decolonization, you've got to actually try and do nose, throat and skin, either with chlorhexidine washes or cheaper version bleach baths.
Interesting comment about eczema. Our nurse practitioners in our clinic run a eczema clinic, and they've actually got data to show by good eczema care reducing hospitalisations, even in our smallish practice. So and that's getting good moisturisers and getting steroids at the right time. And bleach baths and all that sort of stuff, so it can make. And as you may be aware, cellulitis is the biggest reason for admission to a New Zealand hospital, and they didn't figure that out until they realised that people were going to paediatrics, adult medicine, orthopaedics and general surgery. And when they actually added it all up, it's the biggest reason for admission, and technically it's preventable, but we're a long way off that.